Hello class, and welcome to your Chapter 6 lecture. Today we're going to be discussing CNS depressants, specifically sedative hypnotics. So it's important to know that CNS depressants are the second most widely used and abused drug. They typically relieve stress and anxiety and can also induce sleep. They're typically used by those who are looking for a physical or a mental break. So the learning objectives for this lesson are that by the end, you should be able to identify the primary drug groups used for CNS depressant effects, explain the principal therapeutic uses of CNS depressants and their relationship to drug dose, explain why CNS depressant drugs are commonly abused, identify the unique features of benzodiazepines and how dependency develops, describe the differences in effects produced by short versus long-acting CNS depressants, describe the CNS depressant properties of antihistamines, and compare their therapeutic usefulness to that of benzodiazepines. List the 4 principal types of people who abuse CNS depressants. Identify the basic principles in treating dependence on CNS depressants. Explain the unique properties of propofol as a potential drug of abuse. Explain why GHB is abused and how it relates to its analog compounds. And finally, to explain the role of detoxification in the treatment of CNS depressant dependency. So let's begin by discussing why CNS depressants are problematic. Well, first we need to understand that they're typically prescribed by a physician, so they can be readily available. Also, alarming and dangerous behavior can present if it's not properly supervised or if the person is using these drugs chronically. Also, unrelated drug groups can cause CNS depression and typically is the cause of death by drug overdose. When CNS depressants are combined, dangerous interactions can result, such as death. And disruptive personality changes can also occur when CNS depressants are used. So let's start with going over the history of CNS depressants. So our first is alcohol, which is historically the most common depressant. In the 1800s, bromides came around and they are a toxic substance. Then in the early 1900s, we discovered barbiturates, which we can have issues here with both tolerance, dependence, and even having lethal overdoses. So the amount that's necessary to treat anxiety also can cause depression of the CNS system. So there's a low margin of safety with these drugs. This was replaced by benzodiazepines in the 1950s, which are safe when they're used short term. However, long-term dependence can occur and subsequent withdrawal issues, which led us into the 1970s and 1980s epidemic of prescriptions being written for CNS depressants, which is where we find ourselves today. So what are some of the effects that CNS depressants have, looking at benefits and risks? So the first is that they can reduce CNS activity and diminish the brain's level of awareness. So when we look at antihistamines, these are over-the-counter allergy medications or even sleep aids. They can also cause mild depression of the central nervous system and relaxation. So looking at sedatives, their purpose is to relieve anxiety, fear, and apprehension. They can also have muscle relaxing properties. And this drug can actually relieve anxiety and has been prescribed for that. So then we look at hypnotics, which promote sleep. So if we look at hypnotics, an amnesiac is just when it causes loss of memory, which can occur when you take a hypnotic. And then we have a controlled state of unconsciousness that can result. So this is when we use these types of drugs for anesthesia, which is simply a state characterized by loss of sensation or consciousness. So often the only difference between a CNS depressant being either a sedative or having a hypnotic effect is simply the dosage that's given. And used persistently, tolerance can develop, which then leads to dependence, and then withdrawal symptoms, which can also include seizures. So let's go through the different types of CNS depressants. First, we're going to start with benzodiazepines, which is a Valium type drug. So this was widely used because it has a wide margin of safety, but it is a Schedule IV drug because of its dependence issues. So when we look at medical uses, it's been used to relieve anxiety, relax muscles, induce sleep, or induce amnesia, to relieve withdrawal symptoms of narcotic and alcohol dependence even. So it selectively affects neurons that have receptors for the neurotransmitter GABA. And GABA is an inhibitory transmitter in the limbic system, which alters mood, the reticular activating system, which causes drowsiness, and the motor cortex, which relaxes your muscles. An antagonist drug to this is flumazenil. So currently there's about 15 types of benzodiazepines that are available in the United States. And when we look at side effects of benzodiazepines, we see drowsiness, lightheadedness, lethargy, mental and physical impairments. You can have skin rashes, nausea, even a diminished libido or menstrual cycle irregularities, and a sensitivity to alcohol and other CNS depressants. So when we look at paradoxical effects, these are those unexpected or unintended effects of the drug. These can include nightmares, anxiety, irritability and sweating, extreme agitation, paranoia, and even rage. So Xanax is actually the first drug that's approved to treat panic disorder. So panic disorder is a repeated intense attacks of anxiety that make life unbearable for the person suffering from panic disorder. So Xanax has been a benzodiazepine that's approved to treat that. And then we'll take a look at the tolerance, dependence, withdrawal, and abuse of benzodiazepines. So some symptoms of withdrawal can actually mimic the condition which the benzo is to be treating. So including drug dependence, this can happen after just 1 month of use. Long-term abuse can actually result in panic, depression, paranoia, and convulsions. So again, even though Xanax is approved to treat panic disorder, too much, or when you build up a tolerance to it, that person could experience those same symptoms that they're trying to treat. And cravings for benzos have been seen in those who are not weaned properly from the drug because it's not reinforcing, except those with a history of alcoholism, which is roughly 25% of those who use benzodiazepines chronically. So when we look at barbiturates, they're typically used to treat similar disorders and similar symptoms, so anxiety, agitation, insomnia. They do have a narrow margin of safety, and they've also been referred to as downers, rainbows, Christmas trees, sleepers, and yellow jackets on the street. Those are some of the street names. So when we look at the effects of the medical uses, they depress activity of muscles and the central nervous system. They can decrease blood pressure, heart rate, and even the flow of urine. Liver damage can result because of overuse. They can also prevent convulsions in epileptic patients and seizures that are caused by stimulant drugs. And finally, they've been used for anesthesia for surgery. So when we look at short-acting barbiturates, they're typically Schedule II drugs, whereas your long-acting are going to be categorized as Schedule IV. So initially, a person who takes barbiturate is going to experience acute or chronic intoxication. When they're taken to treat an extreme agitation or mental stress, side effects can include nausea, nervousness, rash and diarrhea, difficulty in making judgments, emotional instability, uncoordination, and slurred speech. So some of these can even repress your REM sleep, resulting in a very groggy feeling than when you wake up. An accumulative effect of taking these drugs can result in death from respiratory or cardiovascular depression because of the high toxicity that's built up in the system. So the mechanism of action elimination, again, is going to interfere with the activity of the reticular activating system, the limbic system, and the motor cortex. They do not act at specific receptor sites, but rather enhance the activity of the inhibitory GABA activity. And fat-soluble barbiturates are more likely to be stored in fatty tissue, which means they can have an effect on men and women very differently. So what are some other CNS suppressants that we should touch on? So some others include chlorohydrate, which is actually a Schedule IV drug. So this is a hypnotic with a narrow margin of safety. It can actually be a stomach irritant, especially with repeated or long-term use. And tolerance and physical dependence can develop with this drug. Methylqualone, this one is a Schedule I drug. It's a sedative hypnotic, and it was used as an anti-malarial drug in India in the 1950s. Its sedative properties were discovered and became available in the United States. However, years after street abuse led to its classification as a Schedule II and then finally as a Schedule I drug. Side effects of this can include nausea, vomiting, anorexia, diarrhea, and headaches. Antihistamines, these are your ones that are to treat common colds, allergies, and even motion sickness. So these act by depressing the central nervous system by blocking acetylcholine receptors in the brain. So in other words, they antagonize the muscarinic receptor, resulting in relaxation and sedation. It does not cause significant psychological or physical dependence or addiction. It is sometimes abused, though, by children or teens and can cause the opposite reactions of restlessness, agitation, and insomnia if abused. Some of the side effects of this drug can include dry mouth, constipation, and an inability to urinate. When we look at new generation of sleep aids, some of them can cause next day sedation, and there is also some dependency that can develop here with these. Propofol has also been referred to as dancing with the white rabbit. So it's used for rapid sedation as an analgesia and general anesthesia. So it's off-label, also used to treat migraines. It has been abused by physicians and nurses, and it has been used to relieve pain or to help with sleep. And then finally, GHB. So this is a Schedule I drug, but it's also a natural depressant. So it's found naturally in the body, and it results from metabolism of inhibitory neurotransmitter, again, GABA. It was first synthesized and used in Europe as treatment for insomnia and narcolepsy. It was then used for sedation, euphoria, and muscle building properties. Today we know GHB as club drugs. It is clear, it is odorless, and colorless. So it has also been used as a date rape drug. It can have a hangover-free high and also aphrodisiac effects. And in large doses, it can cause unconsciousness and even coma. So this was made a Schedule I drug in 2000. What are some patterns of abuse then that we see with CNS depressants? Well, dependence on CNS depressants is considered a psychiatric disorder according to the APA. So when they're taken in larger amounts or over a longer period of time, this would include the psychiatric disorder. When there's a persistent desire or unsuccessful efforts to reduce or control one's use. When much time is spent either acquiring the drug or recovering from its effects. When important prosocial activities are given up or reduced because of the drug's use. When use recurs in physically hazardous situations, such as when the person is driving a car or operating machinery. Intolerance and withdrawal symptoms frequently occur, or when there's continued use despite all of these negative causes. So those are all different points that a psychiatrist would look at to diagnose someone with this disorder. Depressants are also commonly abused with other drugs, such as opioids and alcohol. So opioid users will take depressants to augment the effects of either a weak batch or a shrinking supply of, say, heroin, or to offset the tolerance to opioids, requiring less of the drug then to get high. And alcoholics will typically use depressants to soften their withdrawal or to wean themselves off of the alcohol. Withdrawal symptoms, again, can mimic the disorder that's being treated. So use of the drug may resume due to it inaccurately labeling withdrawal symptoms as the disorder reappearing. So the person may think, oh, I need to take more of the drug, or I need to start taking it again because my symptoms are coming back, when really it's because of overuse or inappropriate use of the drug. And the principal types of people that are most likely to abuse these CNS depressants includes those who seek the sedation effects to relieve continual stress, paradoxically feeling euphoria and stimulation from depressants, to counteract unpleasant effects of other drugs such as stimulants, and finally to combine depressants with alcohol and heroin to potentiate the effects. So how do we treat those with dependence of CNS depressants? So detoxification is going to depend on 3 different factors: the nature of the drug, the severity of the dependence, and the duration of action of the drug. So the goals of detoxification are to eliminate the drug dependence safely while minimizing discomfort. So abrupt withdrawal can actually be dangerous and cause life-threatening seizures. So treatment includes substitution with pentobarbital or phenobarbital and short-acting CNS depressants, using long-acting barbiturates to gradually reduce the dose of the CNS depressant that's being used, vitamins, restoring the electrolyte balance within someone, or even trying to prevent dehydration, and finally, addressing the root cause of the dependence. So maybe an individual was trying to treat their high stress, emotional instability, or even personal problems. It's also worth noting these 2 natural depressants. The kava kava plant is one, and the effects here can include euphoria, increased sociability, relaxation, and sleep. You'll see the picture here on the right. It's actually used to make drinks in other countries. It can cause visual and auditory hallucinations, and some people have even experienced a numb mouth from it. Then the datura plant, the side effects of this one are hallucinations, sedation, and sleep. So these are natural depressants that have been used. So in sum, the primary CNS depressant drug groups include benzodiazepines, barbiturates, and others. The clinical value of CNS depressants depends on the dose. So low doses have a sedative effect, while higher doses are going to have a hypnotic effect. CNS depressants are commonly abused because of their ability to relieve anxiety and reduce stress. Rebound responses to withdrawal of benzodiazepines can actually mimic the symptoms of the disorder that's being treated, leading a patient to begin use again and developing dependence. Short-acting CNS depressants treat insomnia and are more likely to be abused, while long-acting treat persistent anxiety and stress and can help wean from alcohol dependency. Antihistamines cause sedation and drowsiness because of their anti-cholinergic effects, and they are less effective than benzodiazepines. And the 4 principal types of people who abuse CNS depressants include those who are seeking the sedation effects to relieve continual stress, paradoxically feeling euphoria and stimulation from a depressant. They'll also use them to counteract unpleasant effects of other drugs, or to combine depressants with alcohol and heroin to potentiate the effects. The basic principles in treating dependence is to detoxify the person safely while minimizing their discomfort. And propofol is often used by physicians and nurses and has been used to relieve pain or help with sleep. GHB is naturally occurring, but it has been used for sedation, euphoria, and muscle building properties, and it has also been used in sexual assaults as a date rape drug. Finally, the use of short-acting CNS depressants are often used for detoxification and the treatment of CNS depressant dependency. So that was your Chapter 6 lecture. If you have any questions, feel free to reach out, and I hope everyone has a wonderful week.